So how do you identify a patient who has shoulder or neck pain that may have an actual shoulder problem that needs to be treated? Well, in order to help you detect that, there's a few guidelines that I'd like to go over with you. One, things that I call red flags in the history. If a patient has fallen, fractured their shoulder, dislocated their shoulder, or developed sudden numbness in the arm, these indicate that there has been a significant injury to the shoulder. Two, if on exam a patient tells you that prior to one of these traumas that their shoulder was functioning normally, and you find that they can no longer lift their arm, have lost strength in the arm or the hand, these are patients that need a shoulder surgery evaluation, not because necessarily they need surgery, but they need an exact diagnosis in order to guide their treatment. The other type of patient that will need evaluation are patients that come in with the typical complaint that you'll hear as a primary care MD. They have pain in their shoulder. Well, what exactly is pain in the shoulder? It's in the shoulder region, it involves the shoulder blade, and it can involve the neck. So a patient that has pain in any one of those regions is still potentially a patient who has a shoulder problem. Shoulder pain can also interrupt sleep. So if a patient is telling you that they're having difficulty sleeping because of pain in their shoulder, this is a very good early sign to be aware of. And finally, patients will complain of loss of motion in their activities of daily living. Sometimes even reaching between their shoulder blades can be difficult, or reaching for their wallet. If they have any of those symptoms in their exam, you should be on the lookout for a shoulder problem. Now, how do you make the identification once you know you're on the lookout for that? In the exam, there's a few very basic things that you can do that can help you make that identification. The first thing is you must check their range of motion. And the two things you do for range of motion. First, here you see checking a patient for their abduction. Next, you see checking a patient for their internal rotation to the back, which is also known as IRB. If there is a side-to-side difference when you check their motion, this is a sign that the patient may in fact have a significant shoulder problem. Next, you can check for strength. The strength that we're testing is for the rotator cuff. You test the rotator cuff by positioning the patient as you see here, and having the patient push up into your hands. If there is a side-to-side difference and you notice weakness, or if there is significant pain on the injury side, this is an alert that they have rotator cuff problems or a shoulder impingement problem. Impingement signs are also something that should be checked for in the office, and specifically the near impingement sign when the patient elevates their arm in forward flexion. And at the top of forward flexion, they are having discomfort related to the elevation. And this discomfort should be in the shoulder. It should not be in the shoulder blade. It should not be in the neck. It should not run down the arm. It is specific discomfort related to the elevated position in the shoulder. The second impingement sign is an elevation in the abduction arc, where they have pain very much like the near impingement sign as the arm is elevated. If either of those are positive, the exam is positive for impingement signs. Now, other than the red flag history and the loss of motion or strength, which require an immediate shoulder evaluation, if you detect a shoulder problem by their history or by this exam and start treatment, this would be appropriate. And that treatment would be oral non-steroidal medication and physical therapy. And that treatment should go for approximately 6 weeks. If the patient is progressing, then you have probably made the right evaluation and the patient is being well treated. If the patient is not progressing at 6 weeks, I encourage all of my referring sources to stop and reassess the situation. In most cases, the patient should be sent to me to confirm the diagnosis. The other reason to send the patient to me is if they need anti-inflammatory injections in the subacromial space and the glenohumeral joint. Although these injections seem simple, they can be difficult. And since the treatment and the potential need for surgery relies on the results of these injections, I would encourage you to freely use me to perform these injections since they are essential for the patient's recovery.